Alright, hi everyone. I hope you guys are doing well, staying home, taking care. Please let me know if you're having any difficulties that might impact your ability to complete the class, if you're having problems with health-related issues, family issues, or internet issues. I would like to be as flexible as I can for you guys during this difficult time. So, announcements before we get into the videos. Remember that I had these videos recorded ahead of time. So if there's anything that I say in the videos, please let me know if you have questions. Like if there's anything I mention about proctored exam, we're not having a proctored exam. If there's anything that's confusing to you, please let me know. I had these videos ready to go for you guys for the rest of the semester, and then, you know, life changed. I don't think anyone could have predicted the way things played out. So because of that, if there's any questions you have, please let me know. So we had to change things up a little bit with the schedule because of the extended spring break. So we have 4 lecture videos for the last section of the class. So the way this worked out is that for this week, for the week of April 13th, I'm going to be posting 2 lecture videos. So the lecture video you're watching right now is going to be on chapter 14, where we talk about physical, cognitive, and mental health issues in older adults. Then there will be another video for this week. I believe the way that it worked out is that maybe this is lecture 13 and this one will be lecture 14. I think that's right. My numbers may be confused there. But anyway, there'll be 2 lecture videos for the week of April 13th. So because of that, I'm going to be posting these videos as soon as possible to give you guys as much time to watch them. Now, several announcements. First of all, there are 2 activities left after you've completed activity 10. You get 2 drop grades for activities. So I'm going to keep your top 10 activity scores and drop your 2 lowest activity scores. So if you've completed 10 activities and gotten full credit for them, there's no benefit to your grade to completing activities 11 and 12. You can do that if you want to, that's fine, but you don't have to, it won't help your grade. But if you've missed an activity or 2, or if you've scored less than 10 on a couple of activities, then activities 11 and 12 would be a chance for you to earn those points back. So let me know if you have any questions about that. Feel free to ask any grade questions or concerns you have. Now, exam 4 is not going to be a proctored exam anymore. That was initially my plan for verifying identity, but now we've got a new plan, which I'll talk about in a second, which means that exam 4 is going to be exactly like exams 1 through 3. It'll be multiple choice, true, false, and matching. It will cover this last section of the class. It will not be password protected. Now, I chose the dates and times for exam 4 because I thought it would be a proctored exam. So it's going to open at 8 a.m. on April 20th. It's going to close at 5 p.m. on April 24th. If you need additional flexibility, please let me know. If you have internet issues, I would maybe be open to opening it earlier or extending it a little bit. So just let me know if you have questions or concerns about any of that. Now, you do still need to verify your identity. So what we're going to be doing now is an authentication video. Basically, what will happen is that I ask you to record a short video, introduce yourself, show me your ID, which your MEW ID will be great. Any ID that you use, driver's license, etc., needs to have a picture, and you need to cover up any confidential information. You also want to make sure that no one but me can see the video. So there's instructions that are in the assignment that you can follow. But if you have any problems with that or questions, I believe it would be perfectly fine for you to post the video to YouTube as unlisted and then submit the link to your video in that assignment. If it's unlisted, then the only way someone can watch the video is if they have the link. And I would be the only one that would have the link. You'd send that to me through the assignment. And then after I've graded it, you could take that video down if you wanted to. So let me know if you have any questions about that, but you do need to do that to verify your identity. And you'll get 5 points of extra credit for doing so. But if you don't do that, you won't get credit for the class regardless of your grades, because MEW requires students in online classes to verify their identity. So let me know if you have questions about that. So exam 4 will not require a proctor or a password. If you hear me mention that at some point in lecture videos, just disregard the proctor part. I will be posting your grade in the class after exam 4 because you do get a drop grade in the class. So if you're happy with the grade you have after exam 4, you're done. You don't have to take the final exam. But if you missed an exam, or if you didn't do as well on an exam, then the final exam could help you. The only way the final exam can hurt you is if you cheat on it. That could hurt you. Definitely don't do that. Don't plagiarize. Don't cheat. But assuming you do your own work, then it can't hurt you. If it ends up being your lowest exam grade, it'll just be dropped and you'll keep the grade you had before the final. But if the final exam score is higher than one of your exams throughout the semester, it will replace that exam. For example, if you made a 70 on exam 1 and then you made an 80 on the final exam, then the 80 would replace the 70 and add 10 extra points into your points total. If you missed an exam and have a 0 for that exam, and you make an 80 on the final exam, that's 80 points because you're replacing a 0 with an 80. So students who have a particularly low exam score, have missed an exam, are the ones that are most likely to benefit from the final exam. Feel free to email me after you see your grade before the final exam if you would like me to take a look and see if the final exam can benefit your grade. Okay? So please let me know if you have any questions. Remember that I will be posting 2 videos for this week. You only have 1 activity for this week, but you do have 2 videos. So this is going to be the first video. I'll be posting the second video in a bit. Let's go ahead and get into our lecture. All right, so the semester is winding down, and when we go through human growth and development, there's really only one way this semester is going to end. So we've gotten up until the later adulthood period. So today we're going to be talking about older adults, individuals 65 plus. And so we're going to start off by talking about trends in our population. So something we're going to be thinking about today is that people are living longer now, and because of that, we're going to see a higher percentage of the population be made up of older individuals. And here, when we're talking about older adults, we're talking about individuals aged 65 and up. So we're talking about trends. When we look at demographics here, the number of older adults has already increased and will continue to increase. Pretty much true across the board. This is what we're going to see. And what we're going to see is that this trend is likely to continue. It's expected to increase 500% between 2000 and 2050, which we're kind of right in the middle of this. So we're definitely going to see an increase in older individuals. We need to think then about what this means. If we have more individuals who are older, people living longer, then we need to think about perhaps the possibility of people working longer. If you need to save up money for retirement, and if you're going to be living longer, then you might need to save up more money for that. We might need to think about things like Social Security and making sure that we have health care available for older individuals as these percentages change. So, looking at this graph here, you can see that across the board in these different countries, we're seeing at least some increase in the number of older adults, so the percentage of the population that's made up of individuals 65 and older. Here is our line for USA. So in 1950, our population was, what is this, maybe 9-ish% individuals 65 and older. And then what we're seeing right around here is that it's a little bit over 15%, expected to go up to almost 20% in the next 10 or so years. So what we're seeing then is that we're going to have different needs in our population, in our country, in our culture, as the average age in our culture changes. So we know that people are living longer, but this is especially true of women. So in our culture, we see that women across ethnic groups live longer than men, and we're going to talk more about why this might be coming up. So older women are going to outnumber older men. Also, we're going to see that this does change a little bit as far as education demographics. So today, with your generation, more and more people are going to college, pursuing graduate degrees, getting higher education. When we think back to the older individuals, so your parents and grandparents, what were things like when they were younger? We did not have as many people going to school then or staying in school for the amount of time that's average today. So it talks about today only 50% of people 65 and older have high school diplomas. Now, that seems like a very low number to us. When we talk about states that have the lowest high school graduation rate, we're thinking a state that has, in the 80-something percentage seems low. But this is something that is different for your generation than it was for previous generations. So older individuals today are much less likely to have college degrees versus individuals who are getting older, who will make up the next generation of older individuals who are going to be much more likely to have college degrees. So the thought is there is a correlation between education and living longer. And there are several different reasons why this might be. It could be that education truly does help a person learn how to take better care of themselves, physically and psychologically, cognitively. It could be that using your brain and practicing with it more is helpful. But it also could be that if you have better education, then you have higher income, more likely to have insurance coverage, and therefore better access to health care. So there's a correlation here. So you're doing good for your health by going to college now. Even if it feels like college is going to be the death of you, I'm sure you're going to make it through. Now, if we're talking about people living longer, then we need to think about how long do people live? Well, there's a couple different ways to think about this. So maximum life expectancy, how long is it possible for a person to still be alive? There are people that have lived perhaps up to 120 years. Perhaps this could even be possible. However, extremely unlikely, but could even potentially be possible. But you have to think that as an individual gets older, especially when we're talking about very old, over 100, an individual is going to have less quality of life. So there's going to be probably multiple health conditions, going to be frail, that kind of thing. So then we might think about useful life expectancy. So how many years is a person able to be independent? Could be one way to think about this, or to be relatively healthy in their life. So useful life expectancy is going to be lower than maximum life expectancy because we know that as we get older, health conditions are likely to increase. So the average life expectancy, so on average, so about half of people born in a particular year are going to die. So this is what we're looking at here. At the moment, the average life expectancy for women is a little over 80 years, a little over 75 years for men. Now, why are women living longer than men? A lot of different possible reasons. We don't know for sure. It could be that women take better care of their health. It could be that women are more likely to go to the doctor if they have a health concern, maybe more likely to eat right or to exercise, that kind of thing. It could be that there are some kinds of stresses associated with being a man that are decreasing the life expectancy of men. But also it could be that women, being a little bit more relational, might feel more responsibility for taking care of, nurturing children, grandchildren, etc. And so maybe they feel like they have someone who needs them to stick around. They have someone that they're trying to live for. And that could potentially also contribute to women living longer. But one major factor in how long you live has to do with your genetics. And this is especially true for people who live much longer than the average person. So it talks about people who are over 100. Usually this runs in families. And maybe that's because there are some health conditions that could potentially cause a person to pass away earlier that are genetic. And maybe there are some genetics that are related to having great health. But we know the environment is also important. So it talks about exposure to disease, toxins. I think that today we have more information about things that are dangerous. Like just for example, it wasn't that long ago, historically speaking, when we figured out that smoking is dangerous for your health and that it was dangerous for women to smoke while they were pregnant. And so this is something in the 40s and 50s. People were smoking in hospitals, in doctors' offices. Doctors were smoking while they were seeing their patients. Women who were pregnant were smoking, and it wasn't considered a problem. So I think we have more information today about potentially dangerous things, risky behaviors here. I also think that there is work still to be done in this area, especially making sure that people have access to health care. It talks about the healthcare system being broken, and we could debate here, and I don't intend to get into politics, but we know that there are certain parts of the population, and older adults might be especially vulnerable here, that are not able to receive the health care that they need. And maybe because of bad experiences that they've had, they're nervous about going to the doctor, that kind of thing. So certainly there is work yet to be done, although we have made some strides. So when we're talking about people getting older, there are lots of different ways of thinking about getting older and what it means for a person to be older. And the older you get, this number seems to change, right? I can remember when 30 seemed old. 30 doesn't seem old to me anymore. Perhaps it still does to you guys. But when we're talking about older individuals, we have this third, fourth age distinction here. The idea that we have this age where a person is between the ages of 60 and 80. Today, we would consider this the young old. So you're still an older person. At some point during this age range, you're likely going to retire. You're slowing down a little bit, but probably this person still has some pretty good quality of life, probably still able to drive, at least during some of these years. So a person might still have a good quality of life here, but then as the person gets older, we're talking about a person who is 80 and over. There's not a whole lot that we can do at this point to slow down the declines that are going to be happening here because of disease, but then also just related to age. Cognitive decline is going to happen. So although people who are 60 to 80 might be living better than they ever have before, we still haven't been able to find a way to stop the declines that come with being over the age of 80. Okay? So, for this third age, for people aged 60 to 80, we have this increased life expectancy because we have access to medication, vaccines, we have hospitals, things that are available now, research being done. Also, perhaps people know more about how to stay healthy, and so because of that, we have this increased life expectancy compared with previous generations. So then older individuals probably do better as far as physical and mental fitness because we know how to do that. Maybe emotional and personal well-being. It may even be that during the 60 to 80 range, people might have some great strides towards emotional well-being. We're going to talk later about some issues related to depression and how depression actually declines usually as people get older. Certainly possible for mental health to improve. But perhaps during this stage of life when a person is retiring and things are kind of less stressful, less busy for them, then maybe these can be really good years for those individuals. Having said that, though, as we get to that fourth age, so 80 plus, these individuals are likely to start having some pretty significant cognitive declines as well as some health conditions that we may not be able to do a ton about. We're going to talk more about dementia later in this lecture, but dementia is something that we find in 50% of individuals who are over age 90. And there are several different forms that this can take. We're going to talk specifically about Alzheimer's disease coming up. But when it talks about frailty, older individuals, for lots of reasons, are more vulnerable to accidents, so more likely to be in an accident, and then more likely to have severe damage because of that less resiliency as they get older. And then chronic health conditions that then may involve lots of different medications and treatments that could potentially cause side effects as well. All right, so physiological changes that can be happening as people get older. Just a brief review. I believe earlier in the semester we talked about neurons. The neurons are the nerve cells. They make up your nervous system. So the basic parts of a neuron, you have a cell body that is surrounded by dendrites. So you have these little branchy things around the cell body. So the messages come in the dendrites, and then they go down the axon. The axon is this long extension that comes off of the cell body, and the axon is wrapped in a myelin sheath, so that white fatty tissue there that then allows that message to be passed more quickly. And so you're not born with your cells totally myelinated. They're going to be increasing in that myelin throughout adolescence. But then once the message comes in the dendrite, down the axon, goes to the terminal junction or terminal buttons, the other end of the neurons, where they would then cross the little synapse, the little gap, and then carry the message to the dendrites on the next neuron. So what we're going to be seeing is that there are changes in these neurons as individuals get older, and some individuals may develop Alzheimer's disease. Now, there's going to be more on this coming up later in the lecture, I should say. But where does Alzheimer's disease come from? Well, usually there's a combination of factors here. So it talks about neurotransmitter levels. And one thing to say is we don't have all the information about where these diseases come from and how to prevent them. This is certainly still an important area of research. But the neurotransmitters are those chemical messengers that are released from the terminal junction on the end of one neuron. They cross the synapse. They bind to receptors on the dendrites at the next neuron. That's how messages are passed. So neurotransmitter levels seem to be declining. Acetylcholine is one neurotransmitter in particular that is related to memory that individuals might have problems with if they have symptoms of Alzheimer's. But then also we can see these plaques and tangles that can come up in an individual that can cause some symptoms. Now you're going to see this later, but we can only diagnose suspected Alzheimer's because we probably can't see these plaques and tangles very well until we're doing something like an autopsy after an individual passes away. But more on that coming up. So what is happening as people are getting older, especially with their senses? So which senses are declining, which senses are staying about the same? First of all, vision. One issue with vision, night problems. So when it talks about adaptation, really we're talking about your eyes being able to adjust. And one problem that we can see in older individuals is that their eyes may not adjust well to changes in light. So that can be an issue when, for example, you're going from a dark room to a light room, or you're going from inside to outside. But then also it can cause problems with night vision. We can see issues with color vision as well. One thing to note is that this loss of visual acuity is something that can happen gradually over a large time span, and a person might not even realize that it's happening, which means that it is important for a person to continue to go get checkups. I don't know offhand how often you're supposed to go get new prescriptions for glasses. I should know that. I wear glasses. I tend to keep my glasses probably much longer than I'm supposed to before I go back to the eye doctor, but you do need to make sure you're getting your prescriptions checked regularly to make sure they're still accurate. In addition to vision loss that's just happening related to age, we can also see cataracts and glaucoma. Cataracts basically involves this kind of fogginess that can come up in the eye that makes it difficult for a person to see. Glaucoma is related to pressure issues that a person might have in their eye that can also be related to age and can cause vision problems. All right, what about hearing? If we think about senses that decline as we age, then hearing is probably one of the ones that we think of first. And certainly there are some issues that come up related to hearing as a person gets older. This may not be exactly the same for all individuals. Some individuals may have more severe problems than others here. And of course, you know, there are hearing aids and things like that. There's technology that we can use to try to help a person to regain some of that hearing. But one thing to keep in mind is that you can protect your hearing now by wearing earphones, you know, things to block out sound, earplugs, whatever, if you're in a very loud environment because of some kind of machinery. You don't need to be playing your music super loud. If you play your music too loud now because you want to, then when you get older, you'll have to play your music too loud because you won't be able to hear it. So definitely there are things you can do to protect your hearing. But presbycusis here is talking about the individual losing the ability to hear low-pitched sounds. This is associated with aging, and so this is something that we can see. There are lots of different reasons why people might potentially have issues with hearing. So it could be that there's a neuron issue. Once again, we talked about neurons breaking down in the auditory pathway. Metabolism is going to be slowing down, so maybe we're not getting enough nutrition to our receptor cells that are receiving the messages. Maybe it is because a person has been exposed to a lot of loud noises, and then that has impacted the vibrating structures inside your ear. And of course, a person having inner ear problems can also contribute to balance, which we'll mention coming up. And it could be that the receptor cells themselves start to break down, atrophy, weaken here. So there are lots of potential reasons why a person might have hearing loss, and certainly hearing aids can be helpful. What about other senses? Well, there are some that don't seem to change very much. Touch, temperature, pain sensitivity seem to be pretty consistent. Now, when it talks about taste here, taste in and of itself doesn't seem to decline. As far as your taste buds are concerned, there's not a huge decline here from an earlier adult. Kids have more taste buds than anyone else, which is potentially why they're such picky eaters. But going from being a middle-aged adult to an older adult, your taste may not change much. However, it does say that your sense of smell declines, and your sense of smell can impact sense of taste. So there could be some relationship here. But it's especially dangerous for individuals to lose their sense of smell because your senses, all of them, function to tell you perhaps there's something dangerous in the environment. So we know that if you lose vision, if you lose your hearing, then something dangerous could happen. But what happens if you lose your sense of smell? So something like a gas leak, or something could be on fire, there could be smoke, and maybe you miss that because you're not able to smell it. So this is something that's potentially a risk, especially for individuals who have Alzheimer's disease. And then also we know that balance is something that can decline as a person gets older. So reflexes could be an issue here. Person might be more likely to fall, have a hard time recovering if they do stumble. We've already talked about eyesight and hearing, and then muscle tone can also be an issue. A person loses some strength as they get older, and so all of these things can cause a person to be more likely to fall, and an older individual might be more likely to be significantly injured in a fall as well. So something to keep in mind. Briefly thinking about some health issues that can come up. So it talks about diabetes here. There's a distinction between type 1 and type 2 diabetes. Type 1 diabetes is genetic. This is the kind we'd see. Type 2 diabetes, I think there could be a genetic component, but it's much more environmental, as well as the fact that type 1 diabetes is more severe than type 2 diabetes. And so a person with type 2 diabetes might be able to treat that with just checking their blood sugar regularly, because your blood sugar can get too high if your body is not producing enough insulin. Usually the insulin issues are more severe for type 1. So while type 2 diabetes you might be able to treat with checking your blood sugar and a special diet, type 1 diabetes usually an individual has to take insulin, that kind of thing, and is much more likely to come up at an early age, whereas type 2 diabetes usually develops later and can be related to obesity, that kind of thing. We also know that risks for cancer increase as individuals get older, and so there are certain types of cancer that it's more important for older individuals to get screened for. So we think about things like colon cancer or breast cancer. So there's recommendations for when you start getting screening for these different cancers. And so it would be important to keep an eye on that. Lots of other health issues, nutrition-related issues. An older individual might not be able to prepare nutritious foods, might not have access to nutritious food. But it is important to mention sleep here. So babies don't sleep very well, right? Kids, it's kind of individual about how well they sleep. But then you think, okay, when you become an adult, you're supposed to sleep well, right? And that may or may not be the case. Different people have different issues, but as you get older, sleep can become a problem once again. And there are potential reasons why this might be. A person might have to get up to go to the bathroom more frequently, or might have chronic health conditions that might cause pain, discomfort, make it difficult to sleep. But also circadian rhythms. So when it talks about circadian rhythms, your body is supposed to naturally become tired when it's dark outside, and then when you wake up, the light helps you to wake up because your body is going to be producing melatonin in the dark that's going to help you sleep. But what we see with individuals as they get older is that their circadian rhythms can shift. And so people might get tired earlier in the evening and want to go to bed earlier, but then also might wake up earlier. So a person might be going to bed at 8 o'clock and waking up at 4 o'clock in the morning. So we do see shifts in circadian rhythms for older individuals. All right. What about cognitive issues here? So it talks about psychomotor speed, basically a person's ability to respond quickly. So as you get older, your being able to respond is something that we should definitely keep an eye on, because there are lots of different situations where this could be relevant. It talks about all situations, but especially ambiguous ones where a person is a little bit confused. If it's a situation that's new for you, then it's more difficult to process that information quickly, especially if a person is older. So then think about, for example, driving. Is it safe for an individual to drive? And that's a difficult discussion to think about having to tell your parents and grandparents that they can't drive anymore, and certainly I've seen that go very poorly. But wanting to make sure that they're not a harm to themselves or someone else is definitely something to think about. But certainly there are a lot of situations where a person could be at risk because their response time has changed. And this might cause all kinds of accidents to happen. It talks about the brain's white matter here, and this is going back to that myelin sheath. So remember that the axon, that long extension on a neuron, as you get older, it becomes myelinated. It's wrapped in that myelin sheath, which is the white matter in your brain. And that white matter allows the messages to pass more quickly. And so if a person has a health condition like multiple sclerosis where that myelin breaks down, or if a person is older and that myelin has started to decline, then that can slow down a person's response time, make it more difficult for them to think quickly. And so all these things can contribute to the potential for accidents. What about memory? Usually we think about a person getting older and losing memory. So when we talk about working memory here, working memory is not just remembering something, but it's being able to manipulate information as you're remembering it. So when we think about working memory, if I were to call out a list of numbers and then tell you to say them back to me in numerical order, you're not just remembering them, you're doing something with them, putting them back in order. So working memory is something that is small in capacity to begin with. The average number, they say, it's usually somewhere between 5 to 9 items that a person can hold in their working memory, and then that's at the peak. Now, some people have extraordinary memory, and there's things you can do to try to build up your memory, but for the most part, that's the average. But then when a person gets older, this working memory starts to decline, and when you're not able to hold information and manipulate that information, then there are all kinds of tasks that are going to become more difficult for you. Now, an educated individual might be able to find ways to compensate for that. They make notes, and then they take some kind of note-taking implement with them wherever they go so that they can find ways to compensate for that. All right. So then, memory loss is something that people are often afraid of as they get older. I think for a couple of reasons. One, I think we view that as a sign that things are going downhill. But then also we might be afraid of something abnormal, maybe thinking about Alzheimer's disease. So most people are going to suffer some kind of memory loss as they get older, and that's why when you do an intelligence test, you're going to compare someone with their same age peers. It wouldn't be fair for me to measure a 60-year-old's working memory up against a 20-year-old's working memory. So when we talk about these tests, we're going to be looking for a person having issues that are not expected based on their age. And so if it's starting to cause problems in your daily life, if there's some dysfunction here or some distress where a person is very concerned about it, then we need to go in and get some testing. It talks about physical or neurological tests. Sometimes a person might have memory issues that are cardiovascular in nature, so there's some kind of blood flow issue here. If we can treat that, then we can at least prevent it from getting worse, if not at least reverse that a little bit. However, there are certain types of dementia that there's not a whole lot that we can do about those. All right, so if we think about memory going down a little as we get older, we typically think of wisdom going up. Although it mentions here that wisdom is not necessarily related to age, certainly we know some older individuals who still continue to do very foolish things, and certainly there are some younger individuals who make very wise decisions. But what does it mean for a person to be wise? Well, it certainly is helpful to have experience. And to have a fully developed frontal lobe, I think, is also helpful, which happens around age 25. But dealing with important life matters. Being able to get through your day, solve problems as they come, use experience, use judgment, use common sense here. Lots of different definitions. One thing to mention is that sometimes we think of wisdom as being attached with virtue. As in, you are wise if you use what you know for good. We wouldn't look at, I'm making a reference to comic books here, but we wouldn't look at a supervillain and say, okay, well, that person is wise. Even if they are incredibly intelligent, even if they have a lot of experience being a supervillain, because we think that being wise is also attached to being good. So something to think about here. We don't typically consider an evil mastermind as someone who is wise. So wisdom is kind of a combination of being able to use what you know and then also potentially use it for good reasons. All right. What about mental health in older individuals? Well, one thing that we're going to see, and I don't want to talk about this too much because I want to give you something to discuss in your activity that's going to be related to this issue, but as individuals get older, depression tends to go down. Now, there's a caveat to that. It talks about 9% in younger adults, 4.5% in older adults living in the community. Now, if you have to live in a home to receive special health care, then your depression rate is higher. That seems to be related to chronic health conditions, lack of social interaction, that kind of thing. If we look at adults in the community, younger adults, 9%, older adults still living their day-to-day life in the community, 4.5%. So we're going to get to this in a second, but why? Why is this the case? There's a stereotype that as people get older, they should become more depressed because we know what comes at the end of this. We know where this is heading. A person's going to pass away, and so we would think that a person would become more depressed, but actually we see that the depression rates tend to lower. Now, certainly people may not be getting adequate treatment here. I think part of this is because there's a stigma against mental health, which I think is horrific. By all means, go get your counseling. Go do whatever you need to do to take care of your psychological health. Health is health in my mind. But also, people might not be receiving health care because it's expensive or because they don't know where to go or how to find it. So, I want you to be thinking about depression this week for your activity. Why is it that older adults tend to have lower rates of depression than younger adults? What is it about being older that somehow seems to be protective here? I also want you to think about how you would treat an older adult versus how you would treat a younger adult. So, if we're thinking about medications here, if we're thinking about therapy, if there's a certain level of cognitive decline that might interfere with therapy in some way, I want you to think about how you might treat depression differently in an older person than you would in a younger person. So that is your activity for this week. When we're talking about depression, remember that there are two core symptoms. You have to have one or the other or both. It talks about dysphoria here. That's a depressed mood. And so you either have to have that or anhedonia, which is a loss of pleasure. You have to have one or the other or both of those. And then there are several other symptoms that are listed as well. And you have to have 5 symptoms total to get the diagnosis. So with the physical symptoms here, you can see an increase or decrease in appetite, an increase or decrease in sleeping. But when we see older individuals, more likely it's going to manifest itself in difficulty sleeping, difficulty with appetite. There can also be things like trouble breathing. So when you look at this, when you see an individual who is not sleeping, not eating, having trouble breathing, you might think medical condition. And you'd be right to make sure to rule that out. Check on that. But depression might look different from culture to culture and also from age to age. So as people get older, depression might look a little bit different. So you need to make sure that it's not just normal things that you would expect based on their age. Maybe it could potentially be symptoms related to medication. So if they're taking medication for another issue, that could perhaps mimic the symptoms of depression. So definitely something to check in on to make sure that there's not another cause. But if a person has been diagnosed with depression, is struggling with depression, it might look a little bit different in older individuals than it does in younger individuals. So where does depression come from? We could debate this across the age range. Usually there are 2 explanations. There could be 3 explanations. Certainly there could be more than 3, but possible explanations. One, we think neurotransmitter issues. Remember that these are the chemical messengers that cross the synapse. And so this could be serotonin, which is one that's especially related to depression. Could also be dopamine or others. And so it could be that an individual has some kind of issue with neurotransmitters. That's a biological explanation. There could also be a cognitive explanation when it talks about your beliefs. So, do you think that bad things happen to you because you're a bad person and you caused them and everything's going to go wrong? Well, that kind of thinking makes you more at risk for depression versus someone who thinks, well, something bad happened, I'm sure things will turn around, it's not my fault, it's going to be okay. That person will be less at risk for depression. So, it could be that as people get older, maybe they've honed their coping skills. Maybe they've learned how to think differently. Maybe they've learned how to handle stress. Maybe that's one reason why depression goes down as we get older. How are we going to treat depression? Usually there are these two treatment options that are talked about most. Medications, which it talks about selective serotonin reuptake inhibitors. Basically, they increase the effects of serotonin, and that is something that is preferred because SSRIs like Zoloft, Paxil, Prozac, Celexa, that particular class of drugs, tend to have fewer side effects and maybe less dangerous when mixing them with other medications, which older individuals might have. Also, as far as therapy goes, cognitive therapy, changing the way a person thinks, behavior therapy, trying to increase the reinforcement that a person is getting for good behavior, social behaviors, things that make them feel good about themselves. Usually with a more mild depression, you could do either or. And maybe for a particular person, they might respond better to one or the other. As the depression becomes more severe, you might want to think about combining those together. So what about some other potential mental health issues that can come up? Anxiety disorders. So anxiety basically involves a person having the feelings of fear. So your heart's racing, you're hyperventilating, your blood pressure is up, but there's not an actual threat there. That anxiety means you're experiencing the feelings of fear, but there's not actually something there that's dangerous to you. So we do see that depression tends to go down as a person gets older, but this is not always the case with anxiety. It talks about older individuals might feel higher levels of anxiety because of health-related issues, because they're not sure about living situations, or potentially because there could be a side effect of medications, treatments that they're receiving, having to adjust to losing their independence, that kind of thing. So once again, we have the option to treat with medication. It mentions several down here. Once again, I would encourage SSRIs because once again, they tend to have fewer side effects. Something like benzodiazepines, like Xanax or Valium, might decrease anxiety, but they could also potentially increase the risk of accidents. So this is something that's going to make you sleepy, going to impact a person's balance, perhaps. So I would be cautious with that. But then you can also treat this with things like cognitive or behavioral therapy as well. So we mentioned Alzheimer's disease briefly before. It's going to come up again here. Alzheimer's disease is only one form of dementia, and certainly if a person is having symptoms of dementia, Alzheimer's disease is something to think about, but there are other types. As I said, sometimes dementia is created by cardiovascular issues, blood flow issues. With Alzheimer's disease, we don't have a lot of good treatments for Alzheimer's disease. More on that coming up. What you see here is a decline in memory, learning, attention, judgment. So this is where people might start being especially vulnerable to being involved in scams. Individuals might start making decisions, seeing changes in the personality. A person might become very confrontational or very angry or very moody, and that might not seem like that person, easily confused. One of the first signs is often a person losing language skills, so they can't think of the right word to use, that kind of thing. But then also it does get harder for them to take care of themselves, maybe less concerned about personal hygiene, that kind of thing. Now, with an autopsy, you can look at the tangles and the plaques, and you can see the changes there. So after the individual has passed away, that's when you can confirm Alzheimer's disease. That's definitely what was going on. We cannot confirm Alzheimer's disease unless we're doing an autopsy after death. So that means that if a person has been diagnosed with Alzheimer's disease, essentially it's possible, probable Alzheimer's disease. While the individual is still living. And this is a combination of medical testing to make sure there's not something else going on, as well as psychological testing to make sure that the decline is happening. And you're going to interview that person over a period of, depending on the situation, weeks and months and years, to monitor their memory and changes, as well as interviewing family members, doing direct observation, that kind of thing. Now, Alzheimer's disease is definitely something that a lot of researchers are working on, and there is great hope for the future as far as treatments and better understandings of the disease are concerned. Where does it come from? Well, first of all, there's early onset Alzheimer's. This is where an individual can start having these symptoms very early, maybe in their 40s or 50s. We start seeing symptoms. That is different than individuals who are older. It talks about being over 60 and oftentimes even much older than that before the symptoms come on. It seems like the early onset Alzheimer's disease is much more genetic than a later onset, although there could be some kind of genetic risk for the later onset type of Alzheimer's disease, but definitely for the early onset, it's definitely a very strong genetic component. We have identified some genes that are potentially a risk factor, and so more work is being done here, but it talks about an increased risk, especially if you inherited it from both parents. So if this is something that has been on both sides of the family, there's definitely an increased risk for that. Certainly, we are working on treatments for Alzheimer's disease. The treatments that we have right now are not super effective. And certainly it's hard to do research on Alzheimer's disease. There's debate over, with lots of different issues, there's debate over control group. You need a control group to know whether or not your treatment's truly working, but it seems cruel to have a group of people who are given a placebo, a fake drug, and not given the actual drug when it's something that's degenerative like Alzheimer's disease. So certainly there's great debate about the research being done here. The drugs that we have can potentially produce some relief in the moment and maybe can help slow the decline a little bit, but it can't really be prevented. And so this is something that is a vicious disease, one that I have personally seen that can cause a lot of pain. But in addition to drugs and medication, there are some behavioral things that you can do. It talks about spaced retrieval, helping a person to practice information that's very important for them to remember, kind of gradually spacing that over time, using reinforcement for the individual. One thing I just want to say out of personal experience, it is good to love the person where they are, not to expect them to be the person they used to be, and to not try to force them to remember. That's not going to work. You're just going to end up scaring them and confusing them. So just loving the person where they are right now, instead of trying to, you know this person, right? You remember me. Don't do that. Be with them in the moment and try to have realistic expectations for them. That's what I will say about that. When it talks about Montessori educational methods, this is something we usually think about doing with young children, but it's very hands-on, using manipulatives, that kind of thing, could potentially be helpful for individuals with Alzheimer's. Now, another disease that we think about that can occur as individuals age, Parkinson's disease. Now, Parkinson's disease is thought to be produced by dopamine issues, so a person does not have enough dopamine. And so this is going to be treated by giving medication that will increase dopamine. But this is something where those treatments help for a certain amount of time. And then after a while, those treatments are less effective as well. So this is another degenerative disease. The symptoms are usually movement related. So it talks about tremors, difficulty with balance and walking. Dopamine is strongly related to movement. Also, it can involve some cognitive issues. Dementia can be associated here. The primary symptoms are movement related, but you can see some dementia issues here. So once again, we're going to give medication to try to increase the effect of dopamine, but that's not a long-term solution. All right, good. So if you have questions about lecture from today, please feel free to let me know. Remember that you do have an activity this week. You can always let me know if you have questions about whether or not you need to do that, but basically I'm going to give you 2 drop grades for activities. If you have full credit on the first 10 activities, then you're good. You can use these 2 drop grades for the last 2. But if you need to use your drop grade for other activities that you missed or didn't get 10 out of 10 on, then you're going to want to do the activity for this week and next week. All right? Let me know if you have any questions. You guys have a great day.